Good afternoon, dear specialists, MOs, and fellow colleagues. I'm Sorkaji, so I will present about acute appendicitis, whereas my supervisor is Dr. Patrick. So, acute appendicitis is actually the inflammation of the appendix. So, appendix is a hollow organ located at the tip of the cecum, usually at the right lower quadrant of the abdomen. Then the position of the face of appendix is usually constant, and there is usually 3 tinea coli converge at the junction of the cecum and appendix. Then the blood supply of appendix is the appendicular artery, which is a branch of the lower division of the iliac artery. So, most of the appendix, the location is retrocecal, which is 74%, whereas there is some appendix which are pre-iliac, post-iliac, pelvic type of appendix, or paracecal and subcecal type. So this is the picture showing the anatomy of appendix, and the appendicular artery which supply the appendix is actually a branch of the iliac artery. So, we need to know the location of the appendix and where is the point there is the maximum tenderness for a patient come with appendicitis. So, it is usually located at the McBurney point, which is you draw an imaginary line between the anterior superior iliac spine and also the umbilicus. Then, the location between the lateral 1/3 and medial 2/3 of the line is the location of the McBurney point, which is the maximum location, the tenderness which is maximum is located at that point. So the causes, what are the causes that are causing appendicitis? So basically there's an obstruction of the lumen of the appendix. So it may be caused by fecally, appendicoly, which is composed of inspissated fecal material, calcium phosphates, bacteria or epithelial debris, lymphoid hyperplasia, tumor or intestinal parasites such as Oxyuris, vermicularis, or Ascaris species. So a mixed growth of aerobic and anaerobic organisms is usually present, such as E. coli, Bacillus fragilis, Strep fecalis, Clostridium perfringens, or Pseudomonas aeruginosa. So this colonoscopic view of the lumen of the appendix showing the intraluminal debris. And whereas the right side one is the fecal concretions that we may see in the inflamed appendix specimen. So we have to know the pathophysiology why the acute appendicitis can occur. So at first, it basically divided into 3 phases. There is obstruction, increase in intraluminal pressure, and also necrosis and perforation. At first, there is obstruction caused by fecally or like bacterial. So there is some hyperplasia of the submucosa lymphoid follicle of the appendix and the fecality. So it may be due to multiple causes. Then it leads to the increase in pressure of the lumen due to the mucosa secretion and also the bacterial overgrowth. That's why we start the patient on antibiotic whenever we treat the acute appendicitis, because we want to alter the bacterial growth. Then, as a result, the appendicular wall becomes thin and the lymphatic venous obstruction get obstructed. So, as the disease progresses, the appendix may become ischemic and necrotic. So, the bacteria may begin to leak out from the walls and the pus may form around the appendix, causing appendicular abscess. So, the end result may lead to appendicular rupture, causing peritonitis. So, Alvarado scoring is good to help us to identify the possibilities of the patient having appendicitis. So the pneumonic is mentors, which is respective scoring. So symptoms including like migration of the pain, anorexia, nausea or vomiting. Signs we have to look for tenderness in the right lower quadrant abdomen, rebound pain, elevation of the temperature more than 37.3 degrees Celsius, laboratory such as leukocytosis, or when there is a shift of white blood cell to the left, let's say the neutrophils is more than 75% of the white blood cell. So the higher the score of the Avogadro score, that is more suggestive of appendicitis. So for clinical diagnosis, the appendix, we can know whether the possibility of acute appendicitis by the Avogadro scoring. And in the history and physical examination, for the symptoms, we have to look for any periumbilical pain, any migrating pain, where the pain starts from, and so we have to know where is the pain starting from, and whether it radiates to the right iliac fossa, or then whether the patient got nausea or vomiting, diarrhea, anorexia, fever. Then we have to exclude other causes as well, such as whether the patient has any genital urinary symptoms, any voiding symptoms, any frequency, hematuria, pyuria, because urinary tract infection or renal colic may present as pain as well over the abdomen. Then in female, especially like childbearing age, we have to rule out gynecological causes as well. So for clinical examination, we look for the general condition of the patient first, whether the patient is hydrated, whether the patient is septic looking, then the vital signs of the patient. For abdominal examination, we look for any obvious swelling over the abdomen, whether the abdomen is distended, any suggestive features of peritonitis, such as guarding of the abdomen, like borderline rigidity, any report tenderness, any localized tenderness, then any mass palpable or any tenderness at the renal angle. So there's some specific signs which may be suggestive of acute appendicitis, but it may not present in acute appendicitis case, such as the Rossing sign. So when you palpate the left region, there will be pain at the right iliac fossa region. So this is suggestive of peritoneal irritation. You may see the obturator sign, a source sign. So other examination that we have to look for in acute appendicitis, including rectal examination. So in just now, there is some types of acute appendicitis. So if there is the patient may present with tenderness in the right rectal wall in pelvic appendicitis. So we have to do pelvic examination in female as well, and then the patient may have cervical motion tenderness and nasal pain or masses due to gynecological causes. And testicular torsion or hernia is also one of the causes may present as the features mimic acute appendicitis. So we have to try to exclude this as well. So basically, the differential diagnosis for right lower quadrant abdominal pain is quite broad. So for gynecological causes, we have to rule out PID, atopic pregnancy, ovarian cyst, ovarian torsion. Urological causes like pyelonephritis, urinary or colic. There are other causes such as gastroenteritis, mecal diverticulitis, peptic ulcer disease, diverticulitis, cholecystitis, mesenteric lymphadenitis, and hernia or testicular torsion. So for investigation-wise, so FPC will be expect an increase in white blood cell count, and if there is very high counts, more than 20,000 cells per millimeter cube, so may suggest gangrene or perforation. So, however, in some cases, the patient WBC may be within normal range. Then, if we suspect urinary tract infection or urinary causes, we may do urine PB, urine CNS to rule out UTI, and also do UPT in ovulating woman to know whether the patient is pregnant. So imaging is not a must to do things in acute appendicitis. So it usually helps us in trying to ruling out other causes when we query whether this is appendicitis case. And X-ray may help us to know whether there's perforation or whether there's any intestinal obstruction. So ultrasound may be useful in some women and childbearing age. So we can look for any peri-appendiceal fluid collection, thickened walls, or presence of thickening rod tenderness in the case of appendicitis, and to other causes such as urinary stones or gynecological causes. But this is not a must to do. It helps us in ruling out other causes. So CT scan in some cases which we suspicious of other causes such as like diverticulitis, which we make not sure whether this is appendicitis case, so we may do CT scan. So the left picture is the abdominal radiograph showing the presence of a large thickening. So you may see the tubular structure in the right iliac fossa over the abdominal radiograph. Whereas the right picture is the barium enema radiograph demonstrating the thickening of the appendix with distal stricture of the appendix. So this is the abdominal ultrasound examination showing the features of acute appendicitis. So you can see there's dependent edematous appendix, and there is fecal seen as well. So CT scan, the arrow points towards distended appendix with the thickened walls, which did not fill with the colony contrast agent. But in normal appendicitis, usually we don't need to do this scan, but if we suspicious of other causes. So management, basically we can divide into initial management and further management. In initial management, we have to stabilize the patient first, keep the patient near my mouth, start on drips, then see the patient hydration status, if the patient is short or not. If short, maybe we have to start immediately on the patient on drip, then correct all the blood parameters, and for further management, give analgesia to relieve the pain, and also antibiotics to stop the infection progression. So usually, we will give IV omentum 1.2 gram TDS. Later, we have to proceed with appendicectomy, either through open or laparoscopic pathway. So what laparoscopic appendicectomy have some advantage and also disadvantages. The advantage just including shorter hospital stay, increased need for post-operative analgesia, early food tolerance, earlier return to work, and also lower rate of wound infection and post-operative ileus. Whereas the disadvantage, including longer intraoperative time, risk of conversion to open in case of there is dense adhesion seen, and if there may be increased rate of intra-abdominal abscess. So for post-op, we monitor the vital signs, then continue with IV drip until the is fully tolerated already, and we give analgesia for pain relief and wound inspection day 3, suture to off on day 7 to day 10, and if the diagnosis is perforated appendix, the antibiotics need to be completed for 7 days. Whereas if it's just simple appendicitis, we may off the patient antibiotic after the operation. So, so far any questions? Okay, so there are some possible complications of appendicitis, so including appendicular mass when there's an inflammatory phlegmon along with the omentum and adjacent viscera. Whereas for the appendicular abscess, it occurs when there's pus develops within the mass, so it's known as appendicular abscess. So for appendicular abscess, it depends of the size of the abscess. If it's a small abscess, we may give IV antibiotic therapy, followed by the interval appendectomy, can be performed 4 to 6 weeks later. Or if there is a larger well-defined abscess, after purification with IV antibiotic is performed, the patient can be discharged with catheter in place. Then we do interval appendectomy after that, after the fistula is closed. Then if patients with a multi-compartmental abscess, this patient may require early surgical drainage. So this table I get from the up-to-date is quite comprehensive. So acute appendicitis basically divide into perforated and non-perforated type. So for non-perforated type, we need to see first whether the patient is fit for surgery or whether the patient accepts surgery. If the patient is unfit or refused for surgery, we give IV antibiotic and in-hospital observation. If there is improvement, then we can discharge home with oral antibiotic to complete a 10-day course of antibiotic. Whereas if there is no clinical improvement, we need to proceed with immediate appendectomy to save the patient's life. And if the patient is consented for surgery, there's no contraindication for surgery, then we can go to immediate appendectomy. If there's, just now I said there's differentiated into perforated and unperforated. For the perforated type, we can divide it into unstable patient of 3 perforation general, the patient with perforation or generalized peritonitis, or the patient is stable with localized symptoms. So, if there is the patient is unstable or when there is perforation generalized peritonitis, so we have to offer immediate appendectomy followed by 3 to 5 days of IV antibiotic. If the patient has localized symptoms and we found the patient has abscess, if the abscess is less than 3 centimeters, then we do appendectomy followed by 3 to 5 days of IV antibiotic. If it is more than 3 centimeters, we whether we can drain percutaneously or didn't. If no, then we proceed with immediate appendectomy followed by IV antibiotic for 3 to 5 days. Or we can proceed with drain the abscess and we give antibiotic and see the condition after we drain the abscess. If there's appendicular mass, we have to see whether appendectomy is feasible in the patient. If it is not feasible, so we may proceed with ileocecal resection and we give IV antibiotic and the patient is hospital. If appendectomy is feasible, so we may proceed with appendectomy. So for appendicular mass, appendicular abscess, after we follow steps, we have to monitor the patient whether there's any clinical improvement. If yes, we can discharge home with oral antibiotic to complete for 7 to 10 days course and follow up in 6 to 8 weeks. And all patients should undergo an interval appendectomy to exclude an appendicial neoplasm. And those over 40 should also be offered colonoscopy if they did not undergo any colonoscopic screening according to up to date. And that's why we usually send HPE appendix after we do the appendicectomy. So if there is no clinical improvement, let's say just now the appendicular abscess, we just do the percutaneous drainage, there is no clinical improvement, we have to proceed to immediate appendectomy followed by 3 to 5 days of IV antibiotic. So now I proceed with the case. So case scenario, this example of case, Miss S, a 21-year-old lady, nulliparous, no medical illness, no past surgical history. So she is referred from HKM for acute appendicitis. She presents with sudden onset of right iliac fossa pain, pointing natural, non-radiating, associated with nausea and 3 episodes of vomiting. Denies fever, but there's 1 fever episode documented at HKM. And no loose stool, no UTI symptoms, no respiratory symptoms. So on examination, the patient is alert, being comfortable, lungs, CPF, normal. Then per abdomen, there's soft, non-tender, Murphy's negative, renal punch negative, hernia orifices intact, then no mass palpable. DRE normal, no mass palpable as well, and the vital signs are stable. So the patient, because is childbearing age, so is referred to ONT team as well for assessment to rule out for gynecological pathology. So their impression is obvious gynae pathology. So for investigation for HKN, they do the UPT, that's negative. Urine Phoebe, there's ketone trace, so there's possibility of UTI as well. So COVID antigen negative, and the blood results, the WBC, white blood cell is raised, whereas for the platelets and HP is normal. And the ultrasound abdomen, overall features are suggestive of acute appendicitis. So the patient proceeded with open appendicectomy on 2nd of August. So they noted inflamed appendix and thickened at the tip, no perforation, minimal reactive fluid, no pus, and base and cecum healthy. So the patient was allowed to discharge with milk wound inspection on post-op day 3 and discharged with medication, PCM, Voltaren, and only for STO. because there is no abscess, no perforation, that's why the patient is not discharged with antibiotic. So these are my reference. Oh, thank you. So any questions?
Yeah. Any question?